The role given to me is to talk about LV non-compaction and its mimics. The issue which is at stake is left ventricular non-compaction a distinct cardiomyopathy? Is it an acquired trait shared by different cardiac diseases? And third issue is it just a normal variant with superimposed pathology giving it picture of non-compaction? This has come to our notice because we have seen that response to hemodynamic load can give picture resembling non-compaction. So it has been debated for many years whether left ventricle non-compaction syndrome is an anatomical phenotype or distinct cardiomyopathy. However, European Society of Cardiology in 2023 guidelines have dropped the term non-compaction left ventricle cardiomyopathy. According to them, probably there is no distinct entity called non-compaction left ventricle cardiomyopathy. And we will see one or two cases to ruminate on this fact. So this is a 68-year female. She has duration of symptoms of dyspnea of 3 months duration and recent worsening for the last 1 week. And she was in heart failure, although lying comfortably in bed, left bundle branch block and ECG and frequent PSCs. Now the pictures are not great. We had some issues with regard to her transthoracic impedance, sound impedance, but you can see some modified views, and the left one shows you a 5-chamber view. Overall, there is global hypokinesis, low ejection fraction, obvious dysynchrony, denting of the mitral valve, and there would be some mitral regurgitation. The arrows point to the trabeculations actually, and if you see the entire infralateral wall has many of these strands which are standing perpendicular to the wall, and these are hyperechoic in fact, and these are called trabeculations. Let us look at the trabeculation slightly better, focusing on the trabeculation. So trabeculation basically, according to Stolberger, need to be seen distal to the attachment of the papillary muscle. But you do see that even distal to the attachment of papillary muscles, there are perpendicular hyperechoic strand-like structures. And according to Stolberger, they have to be more than 3. You can count, probably they are more than 3. But we would focus on something else actually, and that is that black part actually between the two hyperechoic lines is the compacted myocardium. And we are now looking at basal infralateral segment where these 4 arrows are pointing to. And if you look at the basal infralateral segment, that black part is compacted myocardium. But as you move down towards the apex, you realize that you don't see compacted myocardium at all. But even in the basal part, if you see the ratio of the non-compacted to compacted myocardium, it is certainly around 2. Go in the mid segment of the infralateral wall or the apical segment of the infralateral wall. Here, you see these trabeculations. This is pericardial effusion. Don't confuse that. That's a pericardial effusion. We are talking about these trabeculi, and you don't see any compacted myocardium. The same thing is happening at the apical segment actually. Again, the pictures are not great, but you can see that the apical segment also have these trabeculations. And of course, the contrast is swirling because of spherical remodeling, which we had seen. Now, is there perfusion in these intertrabecular recesses? So we injected contrast. The quality of contrast is nothing great, but you do see that the white arrows show these intertrabecular recesses, and the flow does go in these recesses, showing that these recesses are well perfused. We looked at the stacks of the short axis view on CMR, and we are starting from the apex, and now we are just moving towards the base, and you would see large number of trabeculations being pointed here, and this is the so-called hypertrabeculate area, well perfused, and this white part is all cavity, and you can see that the black part is all myocardium. Because of differential T1, T2 characteristics, you are able to see the difference. And as we move towards the base, these trabeculi are getting smaller. The trabeculi are getting smaller, and then as we move further towards the mitral valve, this is the mitral valve coming in the center here. Yeah, somewhere here, and of course the left ventricle outflow. You did see that point, which was the vena contracta of the mitral regurgitation, but you don't see anything at the base. So you have seen that by two imaging techniques, we have shown you that the compacted myocardium is thin in inferior lateral and anterior wall, and there are prominent trabeculations, and there is intertrabecular recesses actually are getting filled with blood. So let me summarize this case to you. Dilated cardiomyopathy, left bundle branch block, spherical remodeling with left ventricle ejection fraction being 20 to 25%. A majority of these segments are showing hypertrabeculation, deep intertrabecular recesses. Perfusion of these recesses is shown. Non-compaction to compacted left ventricular mass is significantly more than 25%. And of course, thickness-wise non-compaction to compaction ratio definitely more than 2 in affected segments. The question to us is, should we label this as non-compaction left ventricular cardiomyopathy? Last 30 years, we have been using these general consensus criteria for non-compaction left ventricular cardiomyopathy. That is, it is a bilayered left ventricle with a thin compacted layer and a thick non-compacted layer, prominent trabeculations with deep recesses, ratio of non-compacted to compacted, in systole more than 2, in diastole more than 3, evidence of intertrabecular recesses filled with blood from the LV cavity, absence of coexisting cardiac structure abnormalities, and predominant localization of non-compaction, lateral wall, inferolateral wall, and apex. Our patient fulfills all these criteria. So, is it non-compaction? Non-compaction should be an embryological problem. It should be right from birth, isn't it? The question is, why present at the age of 68 years? That itself would raise a big question to the diagnosis of non-compaction left ventricular cardiomyopathy. We also know that in case we do routine cardiac MRI of all patients with heart failure with reduced ejection fraction, 1/4 of them will show criteria fulfilling the criteria of left ventricle non-compaction. Entity is in doubt as a distinct disease, but there is no doubt that more are the segments involved with so-called non-compaction, worse is the prognosis. We also understand that there are pathological criteria described, and of course we have been fed these 3 different set of criteria for almost 30 years, Jenny's index, Chin index, Stolberger index, and that general consensus criteria, I put them all together. For want of time, I wouldn't actually show you Jenny's criteria, Chin criteria, Stolberger criteria, but that is, and of course Patterson criteria was a diastolic non-compaction to compaction of more than 2.3. There is another criteria to look at the non-compact left ventricular mass, but the time is not allowing me to go through that. Few things have to be said. Almost 70% of the autopsied heart, healthy heart, are reported to show some degree of non-compaction. Mimics, there are plenty of mimics. Let me just quickly show you an individual with another patient with dilated cardiomyopathy. This doesn't seem to be moving. Anyhow, we'll skip this. This is not moving. Okay, it started moving. 27 years girl with severe aortic regurgitation. You again see the inferior infralateral wall those kind of changes which will be called hypertrabeculation, and of course the compacted myocardium being thinner, hypertrophic obstructive cardiomyopathy with hypertrabecular left ventricle hypertrophy in patient with hypertension, aortic stenosis because of, and the short axis will show you multiple trabeculations and a thin compacted segment. Perfusion is seen. You can also see this individual 3 days after myocardial infarction showing marked trabeculation in the apex. The patient has apical myocardial infarction, and it has been suggested that the ischemia could be responsible for emergence of prominent intertrabecular recesses and a diminished compacted layer of myocardium. CKD is another situation which can cause picture resembling non-compaction with left ventricle dysfunction, and of course hypertrabeculations can be there in other varieties where the LV dysfunction may or may not be present, like in this particular case. So you have variable phenotypes which can show you non-compaction kind picture. There is variable overlapping genes, variable prognosis, variable reversibility, and acquired variety is well known. Actually, pregnancy is the typical acquired variety. Similarly, actually following aortic valve replacement, the non-compaction has been shown to disappear. And I said the black people have more often this so-called appearance of non-compaction, and so is the pregnant women. The studies have been done in normal individuals showing 6 to 20% prevalence of left ventricle non-compaction in large populations. MESA study has shown actually 6% prevalence. Other studies have shown actually much more prevalence of this thing. But does the non-compaction really exist? Maybe in some patients. Let me show you an example of a 2-month-old child to finish off this thing. This is a 2-month-old child with heart failure. That, of course, looks like non-compaction. That is all. So probability is there, but I think 90% of the time we are overdiagnosed. So let me, okay, so we were seeing that particular baby, and you can see those trabeculations and actually, and of course hypoplasia of the pec muscles. I would skip the important reason why it has been said that there is no distinct entity, because Patterson has shown that trabeculations and compaction go hand in hand. As the gestational age increases, there is more non-compaction and more compaction, more trabeculations and more compaction. So it is not the reverse of the things. Okay, and so let me summarize by saying that there is a tremendous overdiagnosis of so-called non-compaction. Hypertrabeculation is a more appropriate term as suggested by the ESC in 2023 guidelines. True non-compaction as a genetic cardiomyopathy is rare, but probably exists. And more than 90% of so-called non-compactive cardiomyopathy, so-called non-compaction acquired or a variant of normal. So you should discourage the use of non-compaction left ventricle cardiomyopathy and better define the morphological and genetic criteria for that rare patient who has true non-compaction left ventricle cardiomyopathy. Thank you very much.